after lunch that everyone was going to be asleep, but now I'm beginning to fear this time slot because I'm standing between you and lunch. So I promise to keep this on time because, as you can tell, I don't miss many meals. So I certainly don't want to keep you away from missing any meals. But really what I want to talk about today is the diagnosis of PPROM and ask you a question if we're ready to make a change. And what I mean by that is, are we ready to change the way in which we make the diagnosis of PPROM? So think about that as we go through this. As Garrett mentioned, I do have a faculty disclosure to make that I am the Chief Medical Officer of Clinical Innovations. I'll mention several different products that are available out on the market. We want to talk about the implications of diagnosing PPROM, and I'll just talk in general terms of rupture of membranes, whether it be preterm premature rupture of membranes, whether it be premature rupture of membranes, or whether it be just a spontaneous rupture of membranes. So I'll try to use those interchangeably, but when it's important, I'll try to use the right acronym so that you know what I'm talking about. We're going to talk about the shortcomings of the current methodology. We're going to talk about new methodology associated with this diagnosis, and really how do we best utilize these new methodologies, and really in the form of immunoassay testing. So I'd like to introduce to you a patient, just to give you an idea of what we're talking about. This is an 18-year-old first-time mom. She's in an outlying facility, and more importantly, she's at 28 weeks. She's early enough that this particular facility cannot take care of her if she is having complications or if she is to move on to delivery. They've got to transfer her out. The patient reports that she had a sudden gush of fluid, which always makes us a little bit nervous when you hear that history. There was no recent sexual intercourse, no other complications in her pregnancy. She reported no contractions, no bleeding, so it does not appear to be a preterm birth issue, and positive fetal movement. Fetal heart tones, of course, the first thing we do, as we mentioned this morning, we put her on the strip. The fetal heart tones look good. And we perform our sterile speculum exam. We have David standing on our shoulder telling us, do not put your fingers in the vagina. So we do a sterile speculum exam so that we can reduce that chance of infection. The sterile speculum exam says pooling was positive, nitrazine was positive, but the ferning was negative. And we've all run into these before. So I hear a good history, makes me concerned. There's our good chief complaint, but no history. And a positive sterile speculum exam result. So, and unfortunately an ancillary test wasn't done. In this situation, I would have confirmed with an ancillary test, probably a sonogram, but it wasn't done at that time. But given the information that we're given right now, this patient is positive. We should treat this patient appropriately. We should give her get corticosteroids on board. We should be giving her antibiotics, and we should be calling that expensive helicopter to get her transferred to another facility. Which is, oh, very good. All right. So how do we treat the patient? That's what we're going to talk about. I want you to remember this particular patient as we go on later on and talk about, come back to her. So as you know, the fetal membranes serve as a barrier. They're a barrier to infection, but they also maintain the amniotic fluid surrounding the baby that's important for that baby's development, not only in lung maturity, but also in limb development, just normal growth of the fetus. The amniotic fluid has to be present. It also prevents any sort of cord trauma and compression. Now, as we all know, once those membranes are ruptured, it puts the baby not only the baby not only at risk of infection, but mom at risk of infection. It also puts that mom at risk of preterm birth. As we all know, that rupture of membranes, whatever pathophysiology that goes into rupturing those membranes, that's one of the first initiating concepts of the labor process. In fact, when you look at term patients, 95% will deliver within a day of rupturing those membranes. So the overview, or what the scope of the problem is, about 30% of all patients will present sometime during their pregnancy to you or I with the complaint of, I think my membranes have ruptured. Overall, PROM complicates about 8 to 10% in pregnancies. Those aren't too bad because the gestational complications associated with PROM are very minimal. So we treat them expectantly, and we usually get them induced. PPROM is where we run into trouble. PPROM, although doesn't happen as often, about 3%, as Dr. Lewis mentioned earlier, it comprises of 25 to 30% of all preterm labor. So a significant component associated with that. So our preterm labor, complications associated with those, whether it be abruptions, cord prolapse, or even mortality associated with them. I think we're all very familiar with the risk factors associated with PPROM. What we do know is it's multifaceted. Just like with preterm labor, there's lots of things going into the process. There's infection, there's all possibilities of just physical stress of those membranes. But we also know that there are certain things that we should be watching for that increase our risk, whether that be infections, whether that be a history of preterm labor or preterm birth, and shortening of the cervix. In fact, in a multiparous woman who has a short cervix and a history of PPROM, 31 times more likely to have that same thing occur in her next pregnancy. So history, I think, is one of those things that we need to pay particular attention to. And again, you'll hear me come back to that as we get later on down today's lecture. Other risk factors associated with PPROM, whether it be bleeding complications, whether it be chronic use of oral steroids, and I think John is going to talk about the use of those, or maybe it's Garrett. Smoking, drug use, rare but still surprisingly apparent nutritional deficiencies. I think we're all very familiar with the complications associated with PPROM. This is a group that I don't need to go over these complications with. I think we all understand what they are. There's obviously morbidity associated with it, but more importantly, there's mortality associated with it. It's something that we should be aware of and why it's important that we get the diagnosis correct. So management of PPROM really requires that gestational age approach. And what I mean by that is we all know this is a balancing act. We're trying to balance the risk of infection to mother and baby, all the while maintaining this baby in its best incubator, which is mom. We want to try to reduce those chances of complications associated with preterm birth, whether it be neck, whether it be respiratory distress, whether it be interventricular hemorrhages. We want to make sure that we're trying to play that balance and balance the risk of infection versus maturing this baby as long as possible. So the diagnosis of PROM, I think it's important, or ROM, I think it's important to understand. Back in 1963, the American College issued its first educational bulletin. Now this was prior to our practice bulletins that we recognize today, but their first educational bulletin came out in 1963. The first time that PROM was ever even mentioned by ACOG in one of their bulletins was 1988. Number 115, we talked about PPROM, and in the diagnosis of PPROM, which is what I'm talking about today, there was the concept of the paragraph really directed a conversation about the indirect method of making the diagnosis, the classic but antiquated 50-year-old methodology of the sterile speculum exam. Okay, 1988. 10 years later, the first practice bulletin is announced. It's in reference to PPROM. The bulletin contained the same recommendation when you look at the diagnosis. But they did add the ancillary use of the sonogram. 2004, the Obstetric and Gynecologic Survey, volume 59, a CME review article entitled The Evidence-Based Approach to the Evaluation and Treatment of PPROM. Also addressed the diagnostic methodology, referencing an article from 1969 that described the sterile speculum exam. So I think you see where I'm going with this is the old standby sterile speculum exam has been around for a very long time. And there's a lot of literature backing its use, but I think it's also important to understand what its limitations are. Practice Bulletin number 80 in 2007 contained the same diagnostic approach. As you know, I don't need to do this for you. You all did it as medical students. The sterile speculum exam, made up of 3 exams. If we add those, our hope is that the synergistic effect of that will be a better outcome, meaning it'll be more reliable. We'll have a higher sensitivity and higher specificity if we put all 3 observations together. Now, if you're lucky enough to peer in just at the time that you see a gush of clear fluid coming out of the cervical os, you're done. But as you know, we're very rarely that lucky to actually see that phenomenon. So we're left with 3 different observations. Pooling, as we all know, is a subjective observation. It requires a visualization of that posterior fornix. And lots of things can cause a false positive of pooling. Now, obviously, we have a little bit more experience than that first intern in July, but still, it's a subjective observation that we're making in the visualization of how much moisture is there in the posterior fornix, whether it be caused by urine, semen, secretions, or just infection, or whether it's truly amniotic fluid. False negatives are also can be a result of pooling observations, just from a prolonged leakage, someone coming in 12 hours later, and or a very small leak that we don't visualize at that time. Nitrazine is used more often. I find it interesting to see how many hospitals simply use nitrazine, only nitrazine, to rule out rupture of membranes. I think it's important to understand that, remember, nitrazine is just telling us that the pH environment of the vagina has changed. Normally it's acidic. The nitrazine test just tells us that it's basic. It's just an assumption that's made because amniotic fluid is basic. Well, there's lots of other things, as we all know, that can cause the normal vaginal environment to change from acidic to basic. Those all include all those things we've already talked about, including infections, urine, semen, all of those things. False negatives, same thing. If it's a prolonged leakage, if it's a multiparous patient who didn't start contracting but had a sudden gush of fluid, she stayed home until she got contractions, and then she came in 12 hours later when she started finally having consistent contractions. Well, by that time, that fluid may have been absorbed, it may not be as evident, and you may not get your result that you're looking for. I also think it's important to understand, Coy out of Oregon Health Sciences did a review article in obstetrics and gynecology in 2008 and reported the overall sensitivity of nitrazine is very good, but the specificity is poor at best. Very, very poor. And that's because of all the other things that can cause that pH change in the vagina. Ferning, sort of the standby, at least during my training, the ferning was always sort of the standby, the thing that we would be confident in. If we saw ferning, then certainly this patient had to be ruptured. As we know, it requires a microscope examination, 10 to 15 minutes for that slide to dry. Yes, I've been at times looking at a slide that I couldn't find any ferning, and I had a partner look at it, and within the first 10 seconds they found the fern. So it takes some skill. We need to be competent in doing that, but false positives can occur. Fingerprints, I read in the literature, I didn't believe it until I saw it, but it truly can be misinterpreted. Cervical mucus and semen, false negatives if we just have a dry swab, there's prolonged leakage, or you're just not looking in the right place. You're not looking at the right area of the slide, which can happen. Overall sensitivity and specificity, although are better than nitrazine, they're still not great. Now, the numbers are improved if you look at patients who are laboring. But my comment to that is always, if she is laboring, I'm not going to send her home. It doesn't matter what her membranes are. If she's laboring, she's going to stay there. So it doesn't really make a difference. It's the ones that are difficult, the equivocal, the ones that are having a hard time making the diagnosis. That's where it's most important we get this diagnosis right. Because are we going to be able to send her home or not? So then you look at what are our accuracies, and sensitivity and specificity are much lower. So the diagnosis of PPROM, as I mentioned, we put all three together in hopes that with all three together, it's a synergistic effect. We'll increase that sensitivity from 50% up to 80%, and we'll increase that specificity from 16 down or up to 80%. And we get close, about 80%. I'll show you some literature in a moment that shows that. But it's not great. And there are still cases where we have equivocal results. And in fact, Wallace and Neal in 2010 reported in just making the diagnosis, most important diagnosis, those are PPROM, those preterm patients, almost half of those patients, they were unable to determine the status of the membranes after the history and the physical exam, which included the sterile speculum exam. So in the most important patients, we have the most difficult time making that diagnosis. So let's talk about the second patient. This is a 32-year-old G3P2 at 35 weeks, but she has a history. She has a history of not only PPROM, but in this particular pregnancy, she was noted to have a short cervix. They were monitoring that, and her cervix was noted to be short. She was on bed rest, Dr. Fuentes' favorite, bed rest and pelvic rest. She complained of leakage of fluid last evening about 12 hours ago. Wasn't a sudden gush, but just an increased sensation of moisture. But with her history, she came in. No contractions, no bleeding, positive fetal movement, fetal heart tones look great. So they moved to the sterile speculum exam, and you can see it's negative. There's nothing there. And her AFI is not very helpful. Okay? What's your diagnosis? Well, given her history, I'm really concerned about this patient. Given her chief complaint, I'm concerned. But given her physical exam, I can send her home. Remember her. We're going to talk about her in a moment as well. So ancillary testing, ACOG, as I mentioned, from 1988 to 1998 was the addition of the ultrasound. The idea of being able to do ancillary testing to help in these equivocal cases when we have difficulty making the diagnosis. As you know, ultrasound requires not only the ultrasound itself, but someone who's capable of using it and doing it to make a calculation of that AFI or making a calculation of the deepest vertical pocket. It's also important to understand that even if oligo is present, it's not diagnostic of rupture of membranes. It's suggestive of, it's support of what we anticipate, but it's not diagnostic. And ACOG makes that very clear for all of us. And that's important to understand because we're not able to diagnose a small leak, a prolonged leak, or a baby who has some sort of urinary or bladder dysfunction, and there's been low fluid that entire time. It's one moment in time that we're looking at. Of course, there is the gold standard, the amnio-dye study. I haven't done an amnio or seen an amnio-dye study done since I was in residency. Now, there's some facilities that will still do these occasionally, but because of the risks associated with amnio-dye study, because of the skill that's required, we've gone away from doing this. Also important to understand that indigo carmine can also turn the urine blue. So you could also get a false positive from our quote-unquote gold standard. Obviously very invasive, requires a tremendous amount of skill, and the risks associated with that has caused it to go down significantly. So is there a problem with diagnosing the rupture of membranes? And a patient who comes in who is term and has a wet perineum, no. There's not a problem with those. The problem is when it's an equivocal result and it's a preterm patient. That's when the problem arises. And that's where we need to start focusing. So definitive diagnosis can be difficult. As Wallace and Neal mentioned, half of those cases of PPROM were difficult or impossible to determine based on just the sterile spec exam and history. Up to 3% reported by El Massetti, regardless of whether you used the amnio-dye study or not, you still couldn't determine the rupture of membranes. It's also, I think, important to understand that there are limitations, and no matter what we use, we just talked about the gold standard having a potential of a false positive due to urine. All tests have inaccuracies. It's just a matter of what inaccuracies at what level we're dealing with, and trying to put this entire puzzle together, which is our patient. There's costs associated with misdiagnosis. What if it's a false positive? We say you're positive and she's truly not. We're going to incur cost. We're going to bring a patient in that doesn't need to be. We can induce that patient. That could cause complications. How about false negatives? You're not ruptured. Go ahead and go home. Risk of infection, risk of cord prolapse, risk of all sorts of abruptions, all sorts of complications associated with those membranes being ruptured and us not making the proper diagnosis. The costs associated with that are significant. I think we're starting to see that the safety and the satisfaction of our patients, just the response from patients of a potential misdiagnosis has changed. Just over the last several years with the legal ramifications that have come about and the expectations of our patients. It's also important to understand that the laboratory and the CLIA guidelines have really taken charge or taken hold of what we can do. Now, many of us had microscopes that sat off the labor and delivery that we had access to at all times. And if you wanted to look for ferning, you could simply do that. But now CLIA's come in and said, no, that you can't be done. Unless we go through all of the hoop jumping, which includes proficiency testing and all of the validation and correlation stuff, that microscope can't be done. It has to sit in a lab, and some lab graduate's got to read my Fern slide for me and get me the results in an hour. All of these things are going against us in this antiquated use of using the sterile speculum exam. Personal time involved in doing it, the medications involved in false positive results, and long-term complications associated with false negative results. All of those things we should be aware of and we should be paying attention to. And that's really what's driven this advancement. And that's why I go back to my original question to you is, are we ready and are we willing to make a change? Well, the new approaches to the diagnosis of rupture of membranes, I think most of us are aware of this. And the idea was, it stems from basically saying, well, what should be in the vagina when the membranes are ruptured versus what shouldn't be? And clearly it's amniotic fluid. So can we find something specific to amniotic fluid that gives us a better assessment of whether or not those membranes are ruptured? Now, for many years, back in 1975 was when they first started talking about proteins, particular proteins found in amniotic fluid. So there are lots of different proteins that have been looked at. Many of them have really just come by way of research. One particular protein research didn't show much improvement, haven't gone anywhere. But over the years, there's been several tests that have been developed using and diagnosing based on a particular protein found in the amniotic fluid. The key is you've got to find a protein that's in high concentrations in amniotic fluid and is not found in normal other bodily secretions. So it's not going to be found in normal cervical vaginal secretions. It's not going to be found in high levels in maternal serum. And it's going to be low to absent in the vagina if the membranes are actually intact. We also want to make sure that the common contaminants that we have to deal with when we're talking about nitrogen and ferning don't impact these proteins, or at least the test in which we're using. They don't contaminate our results. So something that won't be affected by the presence of urine, semen, or other infections. So there are 3 FDA-approved immunoassay tests that are available on the market today, here that are available in the U.S. There's several more available in European, Asian markets, but here in the U.S. there are 3. All of them use a cotton tip swab to collect the sample. It's not like the fetal fibronectin in that you don't have to use a speculum. The FDA cleared is a blind swab in the vagina, take your sample and apply it to a buffer solution. The buffer solution is basically going to draw the sample out, and then that sample is going to be exposed to immunoassay strip, basically antibodies that are laid down on a strip to give you whether or not you have a positive or negative result, just like a home pregnancy test. You're going to have antibodies that align with the strip and give you those results. There's an internal quality control basically saying that if it reaches the control line, that the test itself was built appropriately and it was stored appropriately and the proper level of fluid was applied to it, so it's working appropriately. And we get our results in minutes. They're all designed to be bedside tests, but with that said, CLIA has come in and said these are all moderately complex tests. Moderately complex means that there are hoops that have to be jumped through if you are going to do it at the bedside. It doesn't mean you can't do it at the bedside, but all of those proficiencies and those things we talked about before with the microscope come into play with these tests, even though they're a very simple one-step process. Swab in the vagina into the buffer solution and then apply it to my strip. There are no gestational restrictions when you talk about Amnisure or ROM Plus, the two older products in the U.S. market. Actin-Prom has a limitation of greater than 29 weeks. They're not affected by semen, urine, other common contaminants, vaginal lubricants, things of that nature. However, blood causes a problem with all of them. Now, one of the things that Actin-Prom has done is they promote the use of their device in the presence of blood. We know about 10 to 20% of all women who present with the complaint of rupture of membranes, there's some bleeding that's present. So they've tapped into that as a marketing, in their marketing approach and said, well, then use our test in blood because we've done a couple of bedside tests to show that it has little interference. Well, just be aware that in their label it actually states that significant amount of blood will cause a false positive result. And that's because the level of protein that they're looking for is also found in maternal serum. So blood is a contraindicated in all three tests. That's something to be aware of. What I tell people is this: if you choose to use an immunoassay test, when you take the swab out of the vagina, if the swab is pink, go ahead and use it. If it's negative, you can be very confident that the protein is not present and she's not ruptured. If it's pink and it's positive, what's her history? Maybe I'm going to do an ancillary test. Maybe I'll do an ultrasound just to confirm. If it's red, throw it away. The chances of blood contaminating your results are significant. I'd get another result or do something completely different at that point. As I mentioned, they're all moderately complex. We talked about that. And they all have external quality control available, which is basically challenges, known positive and negatives that you do on a weekly, monthly shipment basis. That's all CLIA guidelines. Your lab will walk you through that process. And there's potential reimbursement in all of those. Now, this is just a competitive piece, a comparison piece of the 3 immunoassays available on the market. This is actually PPROM's marketing piece, but you can see they're all FDA cleared. They're all CLIA classified as moderately complex. The clinical history, there's a significant amount of history when you look at PPROM, who looks at insulin-like growth factor binding protein 1. Amnisure looking at placental alpha microglobulin, and ROM Plus, really the newest, which is looking at placental protein 12, also known as insulin-like growth factor binding protein 1 and alpha fetal protein. But you can get your results within minutes. It's a simple swab in the vagina, and then read your results once it's exposed to that immunoassay platform. What I want to share with you really are the test performances, because that's what's most important, at least to me. And when I compare this new technology to the old technology, the old standby that we've all been using for 50, 60, 70 years, well, realize that if we use just the nitrazine test, our sensitivity is in the 90s, which is good, low 90s. Our specificity overall reported is 70%. So much better than what COI reported in 16% in those that particular review, but certainly not ideal. 70% specificity. Ferning, what we found earlier, about 80% sensitivity, 75% specificity. But that still means that our false negative and our false positive rates are in the double digits. So let's take everything together and hopefully get a synergistic effect. Let's look at if we add a history, which I think is important. We add an ultrasound result and we take ferning, which was my gold standard. So I'm going to take all 3 of those and put those together, and of course I'm going to get a better result. Truth is, I don't really get a better result. What I get is sensitivity of about 85%, specificity of 78%. I still have double-digit false negative and false positive results that we've been dealing with for years. For years and years we've dealt with this. We get those equivocal results where you have a patient who has a great history, a concerning chief complaint, and our sterile spec is negative, 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 and we ignore it. We just say, you know, I'm not going to pay attention to that because I'm paying more attention to this patient's history. Well, in comes the immunoassay tests, the new technology. If you look at that overall, you'll see that the immunoassay test provides you with a much better performance. Your accuracy goes up tremendously, whether it be sensitivity or specificity. Now you're talking about in the 90s consistently. False negative and false positive rates are in the single-digit numbers. So we've improved our performance. But just as our history has shown us in obstetrics, we have a hard time grasping onto new things because we've been burnt. The only thing that we grasped real quickly was fetal monitoring. And you know where that's gotten us. Beta-HCG was available and reported in the literature 30 years before we ever started to use it to help us determine whether a patient was pregnant. 30 years. So we're slow to take these on, and I understand the caution there given what I had mentioned before. But there's a lot of data to show that these new technologies give us much better information than what we've been using for 50 or 60 years. Now, with that said, it's not a silver bullet. No matter what the marketing guys try to tell you, these tests are not perfect. And if anyone tries to tell you their test is perfect, I would question their data. Because even when you look at immunoassay tests that we use in the emergency room to rule out a myocardial infarction, they still do not claim 100% specificity and sensitivity. Immunoassays, for one reason or another, have great accuracy. They're better than what we've used in our sterile spec exam, but they're not perfect. And so we need to be aware of that when we use these tests. They're not a silver bullet. The literature has shown that they have a false positive rate. In fact, what's reported in the ACOG bulletin is a false positive rate of 19 to 30%. Now, they took two of the worst studies out there and quoted those and gave a very high false positive rate. But I think it's important to understand. Now, what are the false positive rates associated with? I think it was John O'Brien who was talking about this. But essentially, when you have bulging membranes, remember, we're talking about protein. So these proteins, there's this microtransudation of fluid. So you may get a very small leak of protein that leaks across the membranes as that patient gets closer and closer to term. So I get a positive result in a patient who may not be grossly ruptured. The thing is this is pretty indicative of what's going to happen in the next 24 to 48 hours. So just be aware of that. So false positive rates that are a little bit higher, again, not as high as the sterile speculum exam, but a little bit higher, are usually due to, one, the high sensitivity of the test we're using, but also just the stress of the membranes during that term delivery or as the patient gets to term. And then the off chance that we actually get a reseal. That's reported in the literature anywhere between 2 and 13% of the time. I have a hard time making that diagnosis, but it is reported in the literature that this can occur. We can get a reseal of the membranes. And so those may be also a cause of some of these false positive results. But again, as I mentioned, it's still better than what we've been using for years. So in summary, there's no perfect test, but in clinical practice, the immunoassay tests are superior to what we've been using for many, many years. It's more convenient, it's more easy, it's less invasive to the patient, and it gives us better sensitivity, specificity, positive predictive value, negative predictive values. They're all in the 90% range, as opposed to the 70 and 80% range. We want to use all the information that we're given. If I have a patient that has a concerning history and a very good chief complaint, I approach that physical exam very differently than some first-time mom who reports maybe a little increased moisture, but she's had a history of bacterial vaginosis or something like that. So patient history and chief complaint is always should be considered in this picture in putting this puzzle together. And what I encourage people to do is, depending on the concordance between the patient's history, the chief complaint, and your examination or your findings, whether it be the sterile spec or whether you use the immunoassay test, you should put all three together before making your determination and moving on to in treatment. So let's go back to that first patient. Remember, this was the first-time mom, 29 weeks, small facility, needs to be transferred. No sterile speculum exam was positive pooling, positive nitrazine, negative ferning. Okay? The patient was transferred to the regional hospital on the helicopter. The rest of the story, at the regional hospital, they used an immunoassay. It was negative. AFI was normal, and I don't think it surprised any of you. The patient was observed for 48 hours and discharged, and more importantly, she spontaneously delivered 40 plus weeks. So incurred a tremendous amount of costs that really could have been avoided. Now let's go back to our patient number 2 who had that concerning history. Significant history, chief complaint, yeah, maybe, but definitely the history that has me concerned. But the sterile spec was negative, everything, nitrazine, pooling, ferning, everything was negative. We decided to observe her in the triage unit to re-examine because she had a history. We did not want to send her home. The rest of the story, at that same time, they were actually doing a correlation, or they were actually evaluating an immunoassay test they had not implemented yet. But they did an immunoassay test on this particular patient. She was one of those that they did it on. It was positive. So another reason why they decided to just triage her and keep her around. Let's do another exam in a couple of hours. She delivered within 3 hours. So I think it's just important to understand that they're all limitations. There's limitations to no matter what we do. But the improvement in technology and the availability of new tests, I encourage you to look at those and look at the support and the research that's out there. PROM and PPROM, major contributors to the neonatal and the maternal morbidity and mortality, as we talked about preterm birth. The diagnosis of ROM can be difficult. We've all been faced with those situations where we have equivocal results. And how do we treat this patient if we're in a small facility? Sterile speculum exam is not perfect. Even in the best of hands, it's not a perfect exam. Neither are the immunoassay tests, but they are an improvement. And in those outlying facilities, I encourage people to use those just as they started adopting fetal fibronectin all these years ago to help in that diagnosis, to help try to save some money in those inadvertent transfers. The performance is very good. It's in the 90s. False negative, false positive rates are much lower than what we're used to. So with that, I'll stop. I'll open it up for questions, and more importantly, I'll turn it over to lunchtime, which I know is what you're all waiting for. So thank you very much.